welcome back to another episode of Ironwood Cancer Insights. My name is Delaney and I'll be your host. Today I have with me Dr. Julia Brookman. She is our breast surgeon with us over here at Ironwood in the West Valley. Thank you so much for joining us. We're going to be going over some topics regarding breast cancer. So to get started, what are the different types of breast cancer and how can they differ?
So you really have two main types of breast cancer, and that has to do with the structure or anatomy of the breast. So when you think about the breast, you have really two main structures. You have the lobules, which are basically the sacs where the milk is produced. And then you have the ducts, which are little tracts or tunnels that go from the lobules to the nipple, where the milk drains out of. And so you can have cancer that arises from the lobules or the ducts. Now, the ductal cancer is more common. That makes up about 75%, 80% of the breast cancers. And then the lobular cancer is really more like 15% to 20%. Then you have a couple other rare subtypes that you will occasionally see: metaplastic or tubular or Phyllodes tumor or Paget's disease. These are pretty rare ones. So once you have those two main subtypes, then you also can dive into differentiating those subtypes into further smaller groups that really differentiate how certain breast cancers behave. So we use three specific hormones that help us differentiate between those different types, and that can affect prognosis and the aggressiveness of the cancer, and it can give us a better idea of how that specific cancer behaves. So the three hormones that we look at are estrogen, progesterone, and another one called HER2/neu. And so when somebody has a biopsy and it comes back positive for cancer, then these additional hormone studies are sent. And then it comes back with a percentage or a amount of that hormone receptor that's expressed. And so that further classifies the tumor into different subtypes of either positive or negative of each hormone receptor. So the most common type of breast cancer is something called luminal A, or essentially estrogen receptor positive, progesterone receptor positive, and HER2 negative. And so that is a slow growing and easy to treat type of breast cancer. And so it's great that that's the most common type. And so that can be typically treated with a endocrine therapy, which is essentially an anti-hormone pill that treats the cancer in that way. And the other next subtype is called luminal B, and that is essentially where you have estrogen receptor positive and either negative or very weak progesterone signal. And then it can be either HER2 positive or negative. And this one also has a high proliferative rate. It's a little bit more aggressive than the first type, or luminal A, but still treatable. The HER2 positive breast cancers is kind of the third type, and that is one that would be negative for estrogen and progesterone and positive for this HER2/neu protein. And we have special targeted therapies that this type of cancer responds really well to.
Oh, wow.
And then the other one is something that a lot of people have heard about, which is called triple negative. And that one is very aggressive. And that one is negative for all three hormone receptors.
What are some key signs and symptoms that patients should be looking out for in regards to early detection?
Yeah, so certainly early detection is key, because the earlier that you find it, the earlier the stage it's going to be. And so it's going to be easier to treat. And then the survival outcomes are better for early stage cancers. So the key symptoms, I mean, unfortunately, a lot of early breast cancers don't have any symptoms, and we find them on screening mammograms, and people don't even feel a lump. But that's why we do screening mammograms, because we're looking for these early small cancers that are easy to treat. Now, the signs that somebody might have a breast cancer would be a palpable lump, or a lump that they can feel in the breast, a change to their self-breast exam, whether it be skin dimpling or nipple discharge, or even the nipple has slightly changed shape or started to indent, those could all be signs of a breast cancer. There aren't necessarily a for sure sign of a breast cancer, but certainly things that you would want to get checked out.
And if someone does come in and they have a concern for a lump or they feel a lump, what are the next steps that they should take?
Yeah, so that's a great question. So if somebody feels a change or a new lump or anything, the first thing that you want to do is call your doctor. And typically that would be your primary doctor. They can order some imaging, mammogram or an ultrasound. Usually they'll want you to come in for an exam as well, just to see what it is, make sure it's not an infection or something else, that could be easily treated with antibiotics. And then they'll do the imaging, and then typically with that imaging, they'll also give you a referral to a breast surgeon. And a breast surgeon is somebody who is specially trained in managing both benign and malignant breast disease.
Perfect. And then from there, they'll work with oncologists and radiation oncologists if needed?
If needed, yeah. So the breast surgeon, as a breast surgeon, we treat breast cancer, but we also, there's a lot of non-cancerous things that can happen in the breast that also need to be treated. So, just because you're seeing a breast surgeon doesn't necessarily mean you have cancer. There's other things that we treat, but that would be the first step, is coming to see us. We do an evaluation. We might order some additional imaging, like an MRI or a biopsy if needed, depending on what the imaging is showing. And then we would go from there and involve our medical oncologist or radiation oncologist, if there is a malignancy or cancer diagnosis.
What are other things that you do surgery on or that you can help patients with?
Yeah, so infections is a common one. Somebody can get an abscess or an infection or mastitis. We see a lot of mastitis actually in women that are breastfeeding. And so we can help treat that. If the mastitis goes untreated for a while, then people can develop an abscess, which might need to be treated with a drainage procedure, which a lot of times we can do in the office, either with ultrasound and a needle, very minimally invasive, or with just a very tiny incision and numbing medicine. There are some other things that can come up in the breast that can cause symptoms or need to be either watched or maybe treated with excision, but are not cancer, and that can include something called a fibroadenoma, which is a benign, not cancerous breast lump. It's kind of a fibrous knot of breast tissue, essentially, and they can grow. They are responsive to hormones, so we see those a lot of times in women of childbearing age, so women that are 15 to 40, and with pregnancy hormones, they can grow, they can be painful or uncomfortable. And so sometimes those need to be excised. Also, some women can have cysts that can be really painful. And there's ways that we can treat breast pain that has to do with breast cysts or fibrocystic changes or hormone fluctuations that is non-surgical too. There are also a couple benign things that we can find in the breast that are not cancerous, but they can increase the risk for cancer if somebody has them. So, when somebody has a biopsy that's positive for something called atypical ductal hyperplasia, or for short, we call it ADH, or another one is lobular carcinoma in situ. And either one of these increases somebody's risk for developing breast cancer in the future. So we typically will excise the area in some of these lesions, but also will treat them preventatively with chemoprevention, which will lower their risk of developing breast cancer in the future.
Is that the same thing with women that have dense breasts?
So, dense breast tissue does increase the risk for developing cancer. It also makes it more difficult to see small abnormalities on mammograms. So that's a good question, because with dense breast tissue, mammograms can look really white and kind of cloudy. And so very small masses or very small architectural distortions or abnormalities might not be picked up on the mammogram. So an ultrasound can be really helpful for differentiating that, doing additional screening with an ultrasound for women that have dense breast tissue, or an MRI can also be helpful.
And who is considered high risk, and what does that screening entail?
So somebody who is determined to be at higher risk for developing breast cancer is somebody that has a 20% or higher lifetime risk of developing breast cancer. And so typically we use some clinically validated calculators that will help us find that answer or that number for an individual. And that's based on their specific characteristics. It's also based on family history, whether they've had previous breast biopsies and what those results were.
Okay. And then all those characteristics determine on how early they should be screened, or how does the characteristics work?
So in addition to the 20% lifetime risk, there are some other things that will put you in that high risk category as well. And that includes history of chest wall radiation. So, somebody that had a diagnosis of lymphoma had chest wall radiation between the age of 10 and 30, or somebody who has a known pathogenic variant, which is essentially a gene abnormality that's linked to a breast cancer gene. And if somebody has a positive gene, like the most commonly ones you'll hear are BRCA1 or 2, or people call them BRCA1 and 2. Those are the ones I think people always hear about, but there's actually 11 genes that can increase your risk for breast cancer in varying degrees. So, the BRCA1 and 2 have very high lifetime risk of developing breast cancer. And some of the other genes are a little bit lower, but still have a higher than 20% risk.
And then in regards to just general screening, what are the common guidelines for that?
So it's interesting because if you look at all the different societies, there are going to be slightly different recommendations. But in general, women want to start getting their screening at age 40. That's going to be a mammogram. And typically I recommend annually. Some of the societies will recommend biannually or every 2 years, but I recommend annually.
What are some things that people can do at home to lower their risk of breast cancer?
So that's a good question, because there's a lot of things that you can do in modifying your lifestyle that can lower your risk for breast cancer. So one of them is just getting regular physical activity. So 150 minutes a week of, moderately vigorous exercise can lower your risk of breast cancer. Also maintaining a normal body weight. So a normal BMI, between 18.5 and 25, trying to keep your weight at a normal BMI can actually lower your risk for breast cancer, as well as avoiding alcohol. And then of course, smoking cessation if people are smokers. And all of those things can actually lower your risk quite a bit.
And then nutrition, is there anything that nutrition-wise people should be following or no?
Well, maintaining a healthy diet. So, you want to have a diet that's low in unhealthy fats, so saturated fats. You want to have a diet that's higher in protein, higher in fruits and vegetables. They're going to give you all those vitamins and minerals and antioxidants and boost your immune system, as well as like whole grains.
There are risk-reducing surgeries. Who would qualify for those?
Yeah, so typically a risk-reducing surgery is a bilateral mastectomy, and people who qualify for that are people that have the pathogenic mutations of BRCA1 or 2, or another one is PALB2 that you may have heard of. And so that risk of developing breast cancer is so high that actually you can reduce their risk by greater than 90% by doing a bilateral mastectomy. But I always encourage patients to talk to their doctor and assess that risk with their physician, because it can be very specific. Sometimes people may not have a genetic mutation, but their family history is so significant, that you could make the case for a risk-reducing surgery as well.
When someone has a mastectomy, what are their options for reconstruction?
So that's a great question. The reconstruction options really fall into two main categories, and that is either implant-based reconstruction or tissue flap-based reconstruction, which is basically the patient's native tissue that's taken from somewhere else on the body. And then those also can be divided up into immediate reconstruction or delayed reconstruction. Immediate reconstruction meaning they're starting the first stages of the reconstruction process at the same time as the cancer surgery. And then delayed reconstruction meaning the first stages of the reconstruction are started after their cancer surgery.
Okay, and those will obviously vary by every person, correct?
Yeah, there's quite a wide variety of different options, and different people are different candidates for each type. And we work with a lot of really talented plastic surgeons in the area, and I work very closely with the plastic surgeon in planning out exactly what type of reconstruction is going to be best and how we're going to coordinate the process.
Is there one surgery option that's clearly better than the other, or?
So no, actually, I mean, there might be a couple, cases where one surgery option is clearly better, and that has to do with specific subtypes of cancer. But in general, when you look at survival outcomes and risk of recurrence, having a lumpectomy and radiation is equivalent to a mastectomy. So, if somebody is a candidate for a lumpectomy or breast conservation therapy, that's typically recommended. It allows women to keep their natural breast, and it's a shorter surgery. It's an easier recovery. It has lower risk of complications. And actually, if you look at the studies, long term, women have a higher satisfaction rate with breast conservation therapy.
You work with a multidisciplinary team here at Ironwood. Can you explain to us a little bit what that means and how that is?
Yeah, so a multidisciplinary team is essentially a team made up of other physicians and other specialties that are all working together to collaborate and make sure that the patient gets comprehensive care, and looking at the diagnosis from all the treatment angles.
Wow.
So, we have surgeons, but cancer treatment is not just surgery, right? So there's the medical component as well. So we have radiation oncologists and also medical oncologists. And so it's really a collaborative approach between the surgeons, the medical oncologist, and the radiation oncologist in order to give the patient comprehensive care. And then, in addition, we have so many other members of the team that are important. So even, our medical assistants are really helpful in helping the patient navigate through everything that needs to be done, testing and, follow-up appointments. We have our nurses that are really engaged as well as that part, as well as administering all of the medical treatments and therapies. We have another whole portion of our team that's dedicated to supporting the patient in other ways. So we have social workers, and the social workers are really good at providing assistance and helping the patients navigate the healthcare system, as well as assisting them in even understanding their diagnosis, helping them communicate their diagnosis to their family, as well as helping them learn to advocate for themselves and their care. Another resource that the social workers are great for is helping the patient get resources as far as financial assistance if they need that, or helping them establish a medical power of attorney or living will, advance directives, or survivorship plans, or even end-of-life care.
You get all the care in one roof then?
Yeah. So, even in addition to the social workers, we have dietitians that help our patients with figuring out exactly what type of nutrition is going to be best for them, either recovering from surgery or while they're undergoing their chemotherapy, for example. Or we have an integrative medicine oncologist, and she's really great at helping manage side effects and symptoms while people are undergoing their cancer treatment with different supplements. And we also, can bring in mental health providers, rope them into the team as well, because of course, when somebody gets a cancer diagnosis, it's very stressful and a very emotional time. And so having that support as well can be really helpful. We, as physicians and clinicians, we also try to help our patient with obtaining other things that they need throughout their cancer journey, like prostheses, either cranial prostheses, which is a wig, or breast prosthesis, which is an implant that can go in the bra, if somebody's had a mastectomy, or surgical bras for recovery, or even things that can help hold the drains when people are recovering from surgery. That just makes it easier to take care of yourself at home. So, we try to support them in that way as well. There are support groups here at Ironwood. They're both in person or virtual. that people can join for various different types of cancer, and that can create that community of support for patients as well.
Well, thank you so much, Dr. Brookman, for joining us today and going over all of that with us. It was amazing information. If you do have any more questions or you want to visit us and learn more, you can go to our website at ironwoodcrc.com or give us a call at 480-821-2838. Thank you so much.